Hi, everyone, and welcome to the fourth of four videos here on bone scintigraphy for cardiac amyloidosis. This one is entitled Cases, Pearls, and Pitfalls, where we're going to go through several cases and talk through image acquisition and interpretation. My name's Brett Sperry. I'm a cardiologist at St. Luke's Mid-America Heart Institute in Kansas City.
And I am Eric Burgett. I am the Technical Director and Nuclear Medicine Technologist at St. Luke's Hospital in Kansas City, Missouri.
All right. So I'm going to go on to the next slide here, which is just disclosures, and then into a few cases. So this first case is a 59-year-old gentleman, black male, uncontrolled hypertension for many years. His blood pressure was quite elevated here, 167/116. He was on 3 medications for high blood pressure, new diagnosis of atrial fibrillation. And here's his EKG. You can see atrial fibrillation. He doesn't have a lot of voltage here on his QRS complexes. And here's his echo. You may be able to see the moving images where he has a good amount of increased LV wall thickness, kind of bright looking myocardium. If you look on the right image, you could see it looks like the apex of the heart is moving more like this. It's kind of tipping. These are signs that may increase your likelihood of amyloidosis, but you could certainly also see this in hypertensive heart disease and in renal failure, which this patient had. The other thing that I look at on echo is this S prime value, just for those of you who are multimodality imagers watching this. This is something I've been looking at in the past few years, but we normally look at the E prime, which is down here below the line, but the blue star that I put there is the S prime, and if there's some data that if that is 6 or lower, then that can be consistent with something like amyloidosis, and that just has to do with the longitudinal movement of the base of the heart. So we did a PYP study on this gentleman, and this is the planar image where you do, this is 1 hour, so you do see some counts there where the heart should be. Now, of course, you're not sure what this is until you really look at the SPECT image. And here's a SPECT image for this gentleman. You can see in the black and white here what looks like the heart. You see the donor of the heart. What I want to show people, though, is, and this is not great quality here, but just to look at it, I would really recommend really getting into these SPECT images and scrolling through things to really, even if you don't have CT, to really make sure what you're seeing is the heart, make sure you're not seeing a bowel loop or you're not seeing a blood pool that, when looked at in a certain light, kind of makes it look like it's the horseshoe shape of the myocardium. Really get in and scroll through these images to really confirm what you're seeing as the heart. Eric, do you want to add anything as far as looking at these images with respect to the planar and SPECT, and then really getting into the images and taking control?
Yeah, from a technologist standpoint, I mean, this test is a pretty easy test because it requires little to no patient preparation. And any lab doing MPI SPECT imaging should be able to do both planar and SPECT imaging of the Tech PYP radio tracer. From a technologist standpoint, it's very important, obviously, that you make sure that the heart is accurately, in the field of view, and that what you're imaging is the myocardial area. Where it gets to be very tricky from a processing standpoint is when you're looking at things, specifically the SPECT image, and you're trying to line that image up. If you don't see great differentiation between the blood pool and the myocardium there, I mean, that could be that it's a negative study, but it is very important that you are able to scroll through the slices, look at the rotating images, and really do the best to line it up. In this case, this is a positive study, so it's pretty easy. It looks like a traditional SPECT image, just kind of a count poor, tech SPECT image. But on these studies, when they're negative and you're looking at the blood pool, you just have to be very careful that you're not, making something out of nothing. So when you look at that image, sometimes you'll see hot blood pool area and it may look like myocardium, and you might try and line it up. But it's very important to really look through, if you've got CT fusion, or scroll through those images to make sure that what you're getting truly is the myocardium and not a blood pool image. Great,
and we'll see more of that in some of the coming cases. This patient ended up getting genetic testing and had the V122I mutation, which is consistent with hereditary ATTR cardiomyopathy. Second patient here, 60-year-old black male, new onset dyspnea on exertion. He was hospitalized and an infusion of furosemide was started, and he lost about 15 or 20 pounds on this. His NT-proBNP was elevated as well as his troponin. We did testing for a plasma cell disorder, and his serum free kappa level was 12, his lambda was 41, and his serum immunofixation was positive for IgG lambda. His urine immunofixation was negative. This is an interesting study because the lambda is only mildly elevated here relative to the kappa, but lambda is always is more likely to be a bad actor when it comes to the light chains. Kappa can go up non-specifically in inflammation, and also there is this entity called kappa drift where some of the assays for the free light chains have shown sort of a bias towards higher kappa levels. So if you see someone who has a mildly elevated kappa level and their serum and urine immunofixations are negative, then you're probably okay. But you have this patient here who has an abnormal lambda and a positive serum immunofixation. You really have to take this seriously, or you think it might be AL amyloidosis. Given his age and demographics, though, ATTR was also a concern, and he did have a PYP study. This is his planar image at 1 hour. Not the brightest myocardial area that you've ever seen, but you do see where the heart sits. This is what came off the camera here for his SPECT study, and on first blush you don't really see anything here. You see very faint in this color scheme purple, but you can make out a slight, maybe a slight view of the heart, certainly on the left image and the middle image and even the right image. If you scale this image up a little bit, this is what you see. And now you're starting to say, okay, well, maybe this is positive, but if you were to grade this on the SPECT image, normally we think of grading a PYP scan on the planar images with respect to the rib. But if you're going to convert that over and say, I want to grade this as a grade 0, 1, 2, or 3 on the SPECT image, this would be a grade 1 where there's probably some myocardial uptake there, but it is certainly below the rib uptake. But we don't see this very often. And so to me, this was someone who needed further investigation. You have maybe a grade 1/equivocal study here on the PYP, and you have a positive lambda light chain level. This guy needs additional testing. So we sent him for an endomyocardial biopsy. His Congo red was positive, consistent with amyloidosis. And we did mass spectrometry on that, and it was AL lambda type. And so this patient, interestingly, had a bone marrow biopsy that then showed 20% plasma cells, which is quite high and puts him in the multiple myeloma category. And this is really amazing to me, with a lambda, serum-free lambda level of only 40, which is very low. Normally we see several hundreds, even 1,000 or so that free lambda level. So to have just a mildly abnormal lambda level, but then with 20% bone marrow involvement and with the myocardium being involved there, that really is a sobering case to me, and makes the point that you have to take lambda seriously regardless of what the PYP shows, number one, and number two, you can have these PYPs that are kind of borderline or grade 1 when you're looking and grading on the SPECT, and those are the cases that you can see this quote false positive PYP in patients who have AL. Eric, I know we've talked about this case a lot. Do you want to make some comments from a technologist standpoint as far as this first set of images you're getting, and then scaling them up or down, and just how the myocardium interacts with the blood pool? This is a 1 hour study, just to make everyone aware.
Yeah, so on our studies, we acquire at 1 hour, and we take a look at those images. And if we have an image that is usually definitively positive, we will, stop at that point. In some cases, and this might be a case where having a 3 hour image could potentially help, or you might think it would help. But we've seen that really the blood pool between the 1 hour and the 3 hour, there isn't a lot of difference. Instead, what you really see is you start to see more increased uptake, in the bones, on the scan itself. The soft tissue in the blood pool is relatively constant between the 1 hour and the 3 hour for the most part. And in this case, this is a situation where, if you really have to change the scaling to look at the picture to make sure that what you're seeing truly is myocardium and not blood pool. And also having the CT scan in a lot of cases and being able to accurately register those images with the CT can help with the processing and the interpretation. But as you can see in this one, I mean, this is a very difficult study. In one projection, it looks definitively positive, and in the bottom projections, you start to, as you scale it up, it sort of clouds it a little bit. If you start to think maybe it's more blood pool, or that an additional image will be necessary. But
yeah, this is definitely a difficult case, and it speaks to the fact that SPECT, and particularly SPECT CT, can be helpful. And then number two, like I mentioned earlier, if there's any concern, you got to go forward with some additional definitive testing, like endomyocardial biopsy. So our third case here, this is a 75-year-old male with chronic diastolic heart failure. On this study, we did 1 hour and 3 hour images. So on the left is the 1 hour image, on the right is a 3 hour image. And without me even labeling that, you should be able to tell that. On the right 3 hour image, you see more clear delineation of the ribs coming around on both sides. You see the sternum a lot better. On the left image, the 1 hour image, it's a little bit more blurry because, as Eric was saying, you're not getting as much bone and rib uptake, so you don't have that clear delineation. As far as the ratios here, another example of why we're really not doing any sort of grading on the planar images anymore. The 1 hour ratio is 1.46, which is kind of borderline. It's 1.5 has been published as a cutoff there, and 1.3 has been published at a 3 hour cutoff, and you're above that cutoff here. But you could imagine difficulties in where you're going to put the ROI on the left image, because it is quite blurry, and the heart does look on the bigger side. Here are the SPECT images. This is negative. This is a 1 hour on the top, you see, and a three hour on the bottom. And I point this out because I look at these in multiple colors, color schemes. I think looking at the positive images in the color views. The cool view sometimes is helpful because you can more definitively see a positive study. But your eye really sees a negative study well in the black and white images. And here, I see, I'll toggle this on and off here, but, I see a negative or blacker outline of the heart here on the 1 hour image. And oftentimes it's easier to see that on the 1 hour image because there is more blood pool, or there's less bone, less rib. And so you visually see more blood pool. So you can see this donut of the heart or this horseshoe of the heart that's a negative image. This is maybe not the best example here, but you can see it both on the 1 hour and 3 hour, but sometimes it's actually a little bit easier to see the negative study on the 1 hour. If you are not looking at the hot spots, but you're actually looking at the cold spots, you're looking for the negative outline of the heart to tell you this is a negative study. Eric, thoughts on this? I know we just touched on this on the prior one, but blood pool changes from 1 hour to 3 hour. We still see blood pool on the 3 hour, but again, it's probably not really blood pool. It's that is high, but rather it's the bone uptake and the rib uptake is just not as high yet. So you're having this scaling situation.
Yeah, I think these are negative studies are obviously the most challenging from a technologist standpoint, because when you don't see a definitive myocardial border, it takes a little bit more looking at with the processing. Some of the high sensitivity like CZT cameras, you've got to make sure that, you truly have the heart in the center of the field of view. And in this example here, we don't have CT to really overlay it to make sure that we're registered well. But the other problem that you run into is that your eyes kind of play tricks on you, because if you actually look at the count profile of, your blood pool or your myocardium between 1 hour and 3 hours, they're actually relatively constant, given the imaging time. But what you have is in the 3 hour, and you can kind of see it in the spine, is that you have an increased uptake in the spine and the rib activity. And when you're doing these SPECT images, and you're looking at, the myocardium, it's looking and it's normalizing itself to the relative intensity of the hottest pixel. And so it looks like maybe in 1 hour, you've got tons of blood pool, and in 3 hours, maybe that blood pool is diminished. So you might think, well, we're going to have some diminished blood pool, maybe some increased myocardial counts over that time. And we just haven't seen that that's the case. It's really that intensity difference between the bone and the blood pool. So you have to be careful. It's just kind of, you might want to bring it up, scale the intensities of the blood pool or the potential myocardium to be equal. But like Dr. Sperry said, when you look at the 1 hour and you really see that blood pool, the cold spot imaging or the dark outline of the myocardium really stands out.
Perfect. So then we'll talk just about this last case for a second. This is an 87-year-old male, permanent AFib, chronic systolic and diastolic heart failure, CKD. He had a fall at home and came in with heart failure as well, volume overload. He had an echocardiogram, which, again, I'm looking at the similar type things that we looked at on the prior echo. Here is his PYP, and this is a planar view at 1 hour. You can see the AP in the lateral, and the gentleman fell at home, so you see several hot spots there in the ribs, which are most consistent with rib fractures. Interestingly, in this gentleman, he had kind of symmetric rib fractures on both sides. So regardless of how we did the ratios, whether we included the rib fracture or not, came out about the same. But if you are doing ratios, you do want to try to exclude the rib fractures here. But again, we're not, we in our lab are not really focusing on the planar images or the ratios, and we're really de-emphasizing that and emphasizing the SPECT images. And here's what we have for this gentleman's SPECT. You can clearly see myocardial myocardial uptake counts in this gentleman. And again, we're having what looks like lower myocardial counts compared to what we normally see on these studies. But again, this is a scaling issue, probably because he had several rib fractures, and you see on the top left image there, you see a very hot portion of the rib, which is consistent with this rib fracture. So you're having everything scaled to that, and the myocardium does not look very bright. So like in the case before, you may need to do some alternative normalization here or change the scale up and down to get a clear sense of what you're seeing in the cardiac silhouette, whether you're seeing the myocardium or you're not. Eric, thoughts about this case with respect to the rib fractures and the scaling? I mean, it's kind of what we've been speaking about with the prior cases as well, and the points that we really want to hammer home there. But any additional thoughts on this one?
Yeah, when you're processing this study, obviously, and you're looking at the planar imaging, which they've set the ratios as positive and negative, but that's based on looking at the counts in the myocardium or the blood pool to the contralateral lung. And as Dr. Sperry said, in this case, we were just kind of lucky because he had sort of this bilateral rib fractures on each side that was contributing artifact to the image. But many times you'll have just a hot rib fracture, or you'll have an area where you've got some problems. And it's just very important that you don't draw your ROI so that it encompasses that, because it can falsely elevate or underestimate your ratio there. So in situations where that occurs, the other problem that you can run into is if you make your regions of interest too small on either side, or you have to move it and it's in the diaphragm, or the liver or some other area instead of the contralateral lung, the problem is you're going to get a false ratio at either 1 or 3 hours. So in this situation, this is where the SPECT image becomes crucially important, so that you can see whether it truly is a positive study or not.
Exactly. All right, so we'll just close up here. There's some opportunities and pitfalls here with respect to PYP imaging, and some opportunities are that this is a non-invasive diagnosis of ATTR cardiac amyloidosis. There's some prognostic abilities potentially. We're using earlier and earlier phase imaging protocols. And pitfalls that I want to talk about: don't diagnose definite ATTR on pyrophosphate testing without checking for a plasma cell disorder. Don't interpret PYP on planar images alone. And don't be afraid to order an endomyocardial biopsy. It has enabled the diagnosis to be more reliable and to be reliably made without needing a biopsy, which is fantastic. But really need one if in equivocal type cases. Really have to work up AL amyloidosis and SPECT. If you have SPECT CT, that's great. If not, at least acquire the SPECT images and review them. Look on dedicated cardiac software through the SPECT, scroll through the heart. Really make sure that what you're seeing is myocardial uptake or not myocardial uptake, and just blood pool or some other bright anatomy there, because the consequences of a false positive or false negative study can be terrible, really. Can be life-threatening if you don't diagnose this properly, and can be very expensive if you're treating a patient based on a negative study. So that's what we have for this last segment of the webinar, and thank you again for tuning in.